Hello, everyone. My name is Becky Haas. How is everybody doing today? Okay, so how many pharmacists do we have here? Oh my gosh, so many. There's one. Good. That's way more than last year and the year before and the year before that. So typically speaking, you don't get to see too many presentations by pharmacists is what I'm assuming. Is that maybe correct? Okay, so this might be a little bit different. So I'm Becky Haas. I'm a substance use disorder and pain clinical pharmacist at University of California in Davis. And then we also have Holly, who also is a substance use disorder pharmacist and does opioid stewardship at UC Davis Medical Center inpatient. So I work in the ambulatory care setting in a clinic, and Holly works on the inpatient side. We're going to talk a little bit more about what that looks like throughout the presentation, but that's who we are. And so we'll talk a little bit more about what we do, so you'll get a clearer understanding as we move through this. Well, I have no financial disclosures. And then, of course, maybe some of you have seen this slide today. It's National Recovery Month, September, so yay. Okay, so Holly and I kind of had some bets going, like how many people are actually going to show up to a presentation called DAW1 have any idea what we're actually going to talk about today. So what are we doing here? Why are we pharmacists? What's actually happening? So how many of you have put DAW1 on a prescription and then not had it dispensed as written, or not had it actually dispensed, or gotten a phone call that maybe they wanted something else? Or, okay, so one hand, two hand, three hand. Okay, some hands. All right, so we're going to talk about what pharmacists do, what is the role in SUD management from a pharmacist perspective, and maybe mention some of those barriers that some of you have experienced in working with pharmacists in SUD management. So number one, understand what a pharmacist's role is. Number two, analyze the flow of a prescription from a physician to pharmacist to patient. So what are some of the steps there? So a lot of people actually don't know some of the steps that happen there. We think we know, we think we understand each other's role, right? But I don't think we always do. So sometimes when we understand everybody's role, we have, more empathy towards each other, right? Number three, describe the stigma and barriers to accessing medication for opioid use disorder. And number four, we're going to summarize some ways to mitigate these barriers for accessing MAUD. Okay, so what do pharmacists do in SUD management? Anybody have any ideas? This is like, we're going to actually get some audience participation here. So holler out or say it in the chat. Anybody have any ideas on what a pharmacist is supposed to do in substance use disorder management? They always check cures. Yes, yes. Uh-huh. Yeah. Yeah. So a pharmacist is there to do a little bit of checking on us, right? To make sure that we're, things are okay and going right for the patient. So they're checking the California PDMP or cures, making sure they're not, if they just got prescribed Suboxone, as you were mentioning, maybe they shouldn't get oxycodone right after that. Let's get some clarification on that. So yeah, there are flags that come up. Anything else? Yeah, they look, yeah, drug interactions, allergies. Okay. Zoom says, help us to get to the right place to get the prior auths approved. All right, so those are good examples. So let's talk about a couple different types of pharmacists and what their roles actually are, and maybe fill in some gaps here. So the community pharmacists, retail pharmacists, work at Walgreens, think Rite Aid, think, Walmart, all of those different places. Independent pharmacies, those are all considered retail or community pharmacies. That's where you're going to send your prescriptions to have the pharmacist fill them. So first thing we do is we're going to verify and dispense prescription medications. We're going to counsel your patients on the appropriate use of the medications. So there's actually a law in California, we have to counsel all patients on every new script, or at least offer counseling. We're going to navigate the insurance barriers. We're going to act as gatekeepers for appropriate medication management. That's a little bit of the Colorado PDMP, or California. Sorry, I'm from Colorado. I mix up the two all the time. The California PDMP. We're going to monitor that. We are going to notice some DDIs and some adverse drug reactions and maybe provide some alternative recommendations. We also have to manage prescription and over-the-counter inventory. We're responsible for pharmacy regulatory compliance. So that's one that's scary as a pharmacist. When the DEA comes to your pharmacy or the state board comes to your pharmacy, if you've ever been a pharmacist in that circumstance, it's very nerve-wracking. They likely, if you have anything, no I's dotted, T's crossed, they'll shut down your pharmacy that day and you won't be able to dispense anything. So it's a very nerve-wracking scenario. And then medication therapy management, there's a couple different things we can do there in terms of, the stuff like, maybe they can do some screenings, different things to help patients. So that's retail. That's all the things involved in retail, or at least most of the things involved in retail. Keep in mind that these pharmacists are also doing vaccines. They're also doing sometimes hypertension management, lipid management, all these other tasks as well. So they're kind of like, they're the frontline workers. They're the ones that are getting pulled in every which way and doing all of these things all at once. Okay, so this is me. This is my role. So I'm a substance use disorder and chronic pain pharmacist, and I see patients in clinic. So I work, 8 to 4:30, Monday through Friday. I work 2 doors. I have my own office. I see patients via telehealth, video visits. I see patients in my office. I see patients over the phone. And I do in-office inductions. They're pharmacist-led. And I co-prescribe with an addiction psychiatrist. I work directly with him. And actually there's 2 now in clinic, so 2 addiction psychiatrists that I work with. I'll make recommendations for the dose we need to give for an induction. And then I will follow the patient through buprenorphine maintenance therapy. And so I see the patient on a monthly, maybe sometimes weekly basis, because I have time. I have I'm the extra touch point. So I make medication adjustments. I help with withdrawal management. I'm calling the pharmacies to coordinate fills. I'm, counseling the patient, teaching the patient how to take the medication, all of that stuff. Just like, really the physicians in practice. I'm a clinician. And I work under what's called a CPA, or collaborative practice agreement. So a collaborative practice agreement allows me to actually prescribe meds under the umbrella of the agreement. So I can actually write prescriptions for things like naltrexone, acamprosate, clonidine, Zofran, all the things I need. I can order labs such as LFTs anybody actually looks at those anymore. I can do that. And I can also order, infectious disease screenings, looking for HIV, Hep C screenings, things like that. So under that collaborative practice agreement, I can do all of these tasks. So I'm taking that load off the providers. So technically, you have to have, the way the CPA works is you have to prove that you have adequate training to provide that level of care. So I have a PharmD. You don't technically need a PharmD to work under a practice agreement, but you do have to have a certain amount of, or prove a certain amount of competency in the area that you're working in collaborative practice. So for example, someone doing, diabetes or whatever, like you have to prove that you know what you're doing with diabetes management before you can work under that practice agreement. So, I had already worked at the clinic. I helped develop the CPA. So they knew I knew what I was doing before we just started the CPA. And so they went, okay, yeah, Becky knows what she's doing. So we'll just write this together and we'll make it easy. And I mean, we communicate, don't worry. I mean, I'm not, going totally rogue here. I mean, we have our weekly meetings and, I'm like, hey, I increased so-and-so's bupe today. He's having some cravings, just wanted you to know. And, oh, okay, thanks, Becky. See you later, or, oh, on the bupe induction, we will come together as a team and I'll say, oh, that our LVN got a, cow's a 14 or yeah, I saw some goosebumps. He's really sweating. Like, I think we need to give 4 milligrams today in clinic and we'll talk it out and we'll, discuss, but yeah, under that agreement, we can write scripts. So, so I also help with transitions of care. So I'll coordinate with other pharmacists like Holly Porras over here, who works inpatient. So if my patients are going in ambulatory care and they're getting admitted for surgery or, whatever, and maybe we need to decrease their bupe dose a little bit because we're going to use full agonists on top of their bupe for surgery for a certain amount of time. I'm going to coordinate all that. I'm going to coordinate that with Holly. I'm going to coordinate that with the surgeon. I'm going to coordinate that with the primary care provider and the addiction psychiatrist that I work with. So I get all those people online and kind of corral everybody so that the patient has good transitions of care between those two places. And then I usually have the availability to see them when they get discharged. So I'll schedule an appointment with myself. Hey, how you doing? How was your hospital stay? How was surgery? And I'll call and check in. So another thing I do, I write policies and procedures. I'll review documents. We'll be working on one, coming up for Spravato. We're trying to do some intranasal ketamine for, treatment-resistant depression at our clinic that, is, happening with substance use disorders, obviously. So that's the next policy and procedure on my list. So I'll be writing that here in the upcoming months. I do tons of staff education, tons of learner education. So I'm teaching all the time, whether it's the addiction fellows, the pain fellows, pharmacy residents, medical residents. I have learners all the time. UC Davis is a teaching hospital. So constantly teaching not only the learners, but also other providers I work with as well. So I'm getting referrals from primary care physicians that aren't as comfortable in addiction management. So they'll ask me questions, Becky, can you help me? I want to dose this one thing or whatever. I got this patient in withdrawal. Can I curbside you? Absolutely. And so I'm kind of a go-to person for them as well. I do research projects with the pharmacy residents. We do one a year. Our current project is looking at how to streamline Vivitrol ordering in our patients with alcohol use disorder, actually, because right now it's a very cumbersome issue because of all the specialty pharmacy rules and regulations. And we want to see more people prescribe it, because I think with pandemic, we know alcohol use disorder didn't go down, right? Only went up. So we want to provide more naltrexone IM treatment to patients. And so we need to streamline that process. So we're doing some education, we're doing some, we're building an Epic Smart Set, if y'all are familiar with Epic. So that's one of the things that I'm going to be helping with, is developing a smart set. So from a pharmacist perspective, how to make it easier for a provider to actually go in and click the buttons and order that med. So a pharmacist has those, those radars on, and they know what to look for. So that's one of the things I do. And then, yeah, I'm part of the clinic administered medication regulatory compliance. So I do daily buprenorphine counts. So we carry buprenorphine in our clinic for, to administer for bup inductions. And so I do that compliance. I'm checking refrigerator temps and all that as well. So helping with that. And then I'm going to turn it over to Holly so she can explain what she does.
All right. So I very much, like Becky said, I'm kind of her inpatient counterpart. So she's in the community setting and the outpatient setting. And I am very much hospital based at the med center. So if you all aren't familiar with the concept of opioid stewardship, if you've heard of antibiotic stewardship or antimicrobial stewardship, it's the exact same concept. We essentially borrowed all of their fundamentals and just replaced antibiotic with opioids. So it's really just the concept is ensuring the safe and appropriate use of opioid therapy. And so that's primarily what my role is. So as you can imagine, that spans into the pain realm, and then it also spans into the opioid use disorder realm, and additionally the substance use disorder realm. So I work very closely with our inpatient substance use intervention team. So those are addiction medicine specialists, physicians, and physician learners that are our consult service that can go see the patients and help get them on medications if they need to. I also work really closely with our substance use navigators as well. And so they're really great resources, both for our patients and for our institution. So the other things I think that kind of differ from what Becky does that I do would be, like she said, we both do a lot of staff and learner education. And that's definitely not going anywhere. Super important to continue to do that. I do a lot of system optimization though, whereas Becky's kind of boots on the ground. She sees the patient, she takes care of one-to-one patients. A lot of my work is more system level work in the sense of optimizing our systems, so then they trickle down to our patients. And so like she mentioned, optimizing our EMR. So making sure that we're getting these orders available for providers. Another thing that I've helped with is with our substance use navigators, figuring out those barriers for our patients that are discharging when the buprenorphine is too expensive. What can we do to make it cheaper? Or naloxone, if they don't have insurance, naloxone can be very costly. So how can we get that to them cheaper? So that's been really rewarding and really great working with those groups. Another thing that I do is a lot of regulatory compliance. As you can imagine, with the opioid epidemic, there are a lot of regulatory agencies requiring different reporting metrics with opioid prescribing and opioid utilization. And so I'm tasked with kind of reconciling the hospital's practices with those regulatory agencies' asks. So that's great, and it drives a lot of practice change. And then the other thing that I do day to day to kind of help mitigate any sort of safety issues with opioids is we have reports that pull in our high risk opioids. And so those could be like our methadone, our buprenorphine orders, our PCAs, epidurals, those sorts of things. And so I provide kind of that second check of, are we optimizing this therapy? Is it safe enough? Do we have naloxone ordered? And then kind of one step further, if it's a new long acting agent, how we confirm it's affordable for the patient. So with methadone and buprenorphine, really helping with those prior authorization barriers before the patient gets to the pharmacy after they're discharged and they run into that barrier. So I think Becky and I could probably sit up here and tell you how valuable a pharmacist ourselves could be to a team. But I think it's also important to kind of zoom out and look at what the literature has shown. So I'm going to hand this back over to Becky so she can tell you a little bit about that.
All right. Thanks, Holly. Okay, so if you look up studies, I think, well, firstly, when I think pharmacists are constantly proving their worth. So that's kind of what Holly and I have had to do to get the jobs that we have, because pharmacists actually can't bill for visits. We can't bill for a lot of certain services that physicians can. So even though I see patients and I have, hour-long visits and I have 30-minute visits and I'm doing telehealth, I can't bill for those. Those are free for the patient. So how do I justify my salary if I'm not bringing in money with my visits? How can I sit in a clinic and do all this work if I'm not bringing in with each visit, right? I save hospital dollars in terms of interventions. We save hospital dollars in terms of offloading physician work. We save hospital dollars in terms of preventing deaths and, all of those things. Anything else you can think of that we do? So we're all
No, I think really to echo the offloading physician work, because everyone, the health systems are strained. That's no secret. And so I think one thing that Becky and I have really been able to do in our roles is we have such amazing provider champions, and they've really been able to basically give us our vision or help create a vision with us. And then we're able to kind of do the nuts and bolts of what needs to happen. But then we have that provider support to really nail it home. And so I think that, offloading work from our providers is huge. And I think that's definitely a place where pharmacists can help.
Yeah. Yeah. And decreasing drug costs too. I think we can add that in there as far as justifying our position. So to justify our role, we're constantly proving what we can do. So if you look at studies that are out there, I had my pick of like, which study do I want to pick that shows that a pharmacist is helpful with substance use disorder management? Okay, I'll pick this one. It's recent. So this is a 2021 VA hospital study. And it has to do with, we looked at patients with diagnosis of AUD and OUD, and they were initiated on either ER naltrexone or Suboxone during their hospital admission. The intervention was essentially a pharmacist-led transitions of care telephone clinic. So basically pharmacist telehealth, that the patients that were discharged basically got pharmacist follow-up after they were discharged. And then the patients in the control group were sent home, but not referred to the pharmacist-led group. And so probably got, the standard length of time it takes to see their provider, right, after a hospital admission. So they looked at these patients for 3 months. There were 150 patients, 54 in the intervention group and 96 in the control group. And there was a pretty decent change in the rate of retention when you look at the two groups. So statistically significant at 1 and 3 months for the ER and naltrexone and bupe for the intervention group versus the control with no pharmacist intervention. And that was, basically at 1 month, it was 77.3% versus 56.8% retention rate. At 3 months, it was a 71.4% versus 48% at 3 months, both statistically significant. So then you look at, then they broke it down by actual individual medication. One was the ER naltrexone that looked about the same, at 3 months, 66.7% versus 34.4%, which was pretty impressive. Suboxone actually didn't show a statistically significant difference, even though percentages were higher in the pharmacist group. But I think that might have to do, with number of patients or, actually time of the study. I'm sure you would actually see a statistically significant difference if you, had more patients or, went further out. But the combined group did show an improvement. So the fact of the matter is, adding a pharmacist, it works. And you look at all these studies, and there are lots of studies that actually support this. So that's just one that I wanted to share. But so what is the data actually showing? And so pharmacists help improve patient outcomes in areas of adherence, prevention of return to use, and we reduce emergency department visit. So we're cost savings on all of that. We optimize care with Matt by assuring that meds are ordered correctly, that they're administered correctly. We're teaching how to give naltrexone as far as like how long to have it outside the fridge, things like that. We're monitoring and managing adverse effects, probably in a decent amount of time, again, because we have the time that the providers don't have. And we're working, on alleviating withdrawal symptoms. We can, also, and we can do that, infectious disease screening that I mentioned as part of my CPA. So I'll send patient referrals to, our infectious disease clinic after, if anything comes up. So I'll also refer patients to cardiology, if they need to, and, some of our groups using, stimulants. So here's an interesting slide. So we, of course, we do all of this, right? As I mentioned, but the number one important thing is we get the drug to the patient, right? We're the last line. That's what we have to do, is we're known to get the drug to the patient. We're the drug carriers. So this is a prescription that shows all the different ways that you can get your prescription rejected by a pharmacist. So all the different little ways that, you're going to get a phone call if you misorder a medication by a pharmacist, right? So there's a little bit of that going on. So why are we making those phone calls? What are the actual steps it takes? So sometimes when this happens, when you get a phone call on one of those prescriptions, you as a provider are like, the patient came in, which was nothing short of a, miracle number one, right? Patient actually came in and showed up for support. Huge. Number two, they actually stayed long enough to listen to the provider and agree to treatment. So that's also huge. And then they actually went to the pharmacy to go get the medication. So also huge. Like they went through all the steps. Like we know what it takes just for someone with depression to go in to see a therapist, right? So someone with substance use disorder, it's just such a higher level for them to go ask for help. So this is a huge, massive deal. So by the time they get to the pharmacy, and then there's a pharmacy rejection, I get it. If there's a pharmacist that won't fill or won't do their part to get the drug to the patient, that's all we have left. That's really frustrating. And the reason I know it is because I've been there. I'm one of the providers sending those meds to the pharmacy. I make phone calls to pharmacists to educate them. I make phone calls. I'm not, there are some great pharmacists out there, and there are some not so great pharmacists out there as far as willingness to learn, willingness to, help and be open-minded. You get that. Same with physicians, same with nursing. It's all groups, right? We're all humans and we all need to learn. And so there's these barriers. So let's understand a little bit of what happens when the actual order gets to the pharmacy. So we know everything that's gone on in the clinic, right? All the steps it's taken the patient to get to the actual clinic and get treatment and get the drug actually ordered. Now we have to get it filled at the pharmacy. So way back in the day, a really long time ago, for 5 years, I worked retail. And so I do remember, and Holly's worked in the retail setting as well. So we both have experience with this. So first we get the prescription. Then we got to stop and answer the phone. Then once we take care of that fire, one of the technicians will enter the data of the prescription. So they have to re-enter it into the system usually. Okay. So then, oh wait, I'll get to that. I got to go give a vaccination. I got to stop what I'm doing. Yeah, I know the patient's in withdrawal. I know. Hold on. I just got to, someone's at my window. I got to go stop and do this. So then I come back from my vaccination and I see the script and I got to verify that it was typed in correctly and there were no errors. So I got to do that. I got to check my cures, right? She knew I got to check my California PDMP and I got to make sure everything is legit. Then, okay, then, oh no, I don't have that treatment plan that my manager says I have to have before I can dispense this. So then I got to stop and ask for a treatment plan. And then I'm going to get yelled at because I know this is a delay in care, but I have to have it. So then I'm going to process the claim and oh no, it requires a prior authorization and won't go through. That sucks because you're like, oh man. So then I got to call the provider and say, hey, can we switch to Suboxone tablets instead of films? Because the films aren't covered and I got to switch. And can you change the quantity? Because this insurance, it only accepts a quantity of 3 tablets a day, not 4. So it needs a prior auth for 4. So if we can change it, the 2s to the 8s, we can cut them and then avoid the prior auth and get it to the patient faster. So I'm telling you, I do this every day. So, okay, so we do that. The pharmacist checks in the C2 order. That one comes in, we have to do that. There's all of this paperwork that comes in with the C2. That's that DEA that's gonna come in and take my license, shut down my store. I gotta check that state board also. Oh no, so I get distracted. The technician is filling it. Great, yes. All right, it's controlled, so they got to double count it, so it takes a little bit longer. And then they need the key to where the controlleds are. Oh, hold on, let me go get it. And then someone, got to recount and do a back count of the inventory to make sure my inventory is correct. Oh no, we're missing a pill. Where did it go? Oh man, we're in trouble. Like if we're missing a pill, we got to document whatever. Meanwhile, patient's pissed, right? The patient's out there screaming, calling like, where's my Suboxone? So then I have to do a second pharmacist verification. I finally get the meds in the bottle. I have to do a second pharmacist verification of the order again. I have to look at the script again. One last final check. Crap. The first pharmacist that checked it missed something. It goes back to data entry. I have to send that script all the way back to data entry. And it goes through all of those processes again. So and literally, I worked at Walmart and we had to scan through, like we would fake it and like get the system to like click through all of those processes to make it go faster. If we had a patient waiting, like the system would stop us. And so it was like this massive delay. And I'm like, I know it's just 30 pills in a bottle. I know I'm counting by 5s. I swear I'm doing it, but it doesn't matter. Like you still have to scan a bunch of times. So anyway, so if we finally do that, then we got to counsel your patient. And then we got to tell them that it's $28 and they only have $23. Oh gosh. Okay. Well, we finally get there. There's all these bumps in the road that can happen. And that's like minor. That was like a minor scenario. I am missing so many things. Like this is just basics, but that's just the basic gist of what can happen to a script when it goes through the system. All right. So Holly's going to talk about some of the barriers, some more barriers that we're facing.
Thank you. Okay, before we talk about barriers, I do just want to go back and reiterate, I'm sure you all picked up on this. The barriers that we're discussing are very much system barriers. Like we are not by any means trying to like single out pharmacists. Like this is a system issue that we have one pharmacist doing all of this. And so very much so with straining the healthcare system, it's a system issue, not a person issue. So that being said, Have you all ever experienced any specific barriers when maybe you went to go fill a prescription at a pharmacy, or you maybe sent a prescription for a patient, or tried to pick one up for a family member? Yeah, what was yours? Yeah.
It was just like another thing. You know, it's kind of just days, that's when they're due to pick it up, but they want
So an extra step. Yeah. So someone in the audience here said that when she was going to or sending a prescription for a patient for Suboxone, the pharmacy required her to input the specific date that the patient was going to pick it up. And that's not typically standard, for other controlled substances like hydrocodone or oxycodone. And so it was just an added step, that we would have to do to put in the date.
another Zoom participant said having a current ID, current insurance.
Yep, absolutely. Having everything current. Absolutely. So the comment here was figuring out kind of which pharmacists are willing and not willing to split boxes or really fill certain prescriptions even, right? Some pharmacists are comfortable filling buprenorphine prescriptions. Other pharmacists say, I'm not dispensing this. Yeah. 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 So the comment was that she had, went to pick up a prescription, and the pharmacist had said, "Are you aware that this patient is pregnant?" And it was for buprenorphine. So a lot of misinformation or lack of understanding of buprenorphine in general and medications for OUD. Any others?
Inventory, they say patients do that day, write a prescription. Call the pharmacy, they say they have it. Patient will go there, and they say they don't have it.
Yep, inventory. Yeah, absolutely. So maybe the computer system is off, and it says, oh, we have 30 tablets or whatever. Then the patient actually gets to the pharmacy, and the technician pulls it out to count it, and they're like, oh, we only have 28. Sorry. That's a huge barrier. Absolutely. Okay. I think we hit honestly most of them. So clearly there are barriers, right, to getting prescriptions. Yeah, sure.
It's like a partial, like, say you only have, they then say, well, too bad, you have to get another prescription. And I'm like, no, you just, so I do just need the other prescription. But I'm kind of like, well, it's the pharmacy, probably you can have it. Or the patients.
Yeah, absolutely. So filling, partial prescriptions and then creating an added barrier of requiring, a separate prescription instead of filling the rest of that initial prescription. That's a huge barrier, right? That's an added trip to the pharmacy for the patient. That's an added step for the provider to send another script.
So also added insistence on a full 30 days between fills.
Oh yes. So essentially what waiting 30 days between fills is, insurances will typically allow patients to fill controlled substances 28 days early. That's when it will go through insurance. Some pharmacists or even pharmacies, they have policies that say controlled substances, specifically opioids, we will not fill early. The patient has to use the entire supply, so that 30 days, and then we'll fill it. So that, as you can imagine, who can get to the pharmacy on the same 30-day mark every month? It's just not feasible. But unfortunately, there are, sometimes it's the pharmacist who, that's their comfortability, they'll only do it every 30 days. There are some specific pharmacies that pharmacists work in that do not allow them to fill sooner than 30 days. So definitely a barrier. Any other ones? Okay. Like I said, I think
The inventory thing, pharmacies have actual
So just with inventory, so there are issues with the amount of drugs that we can get, the amount of medications we can order. So there's limits, and it's actually due to a law that was passed, and you can only order X amount of this drug per month. And so you've heard I have my max morphine patients this month. I can't accept any more morphine patients. They're not being jerks. That's real. That's due to an actual law that happened. And so the same thing is happening with buprenorphine. They're limited on the stock that they can order. So unfortunately, when you can only order X amount at a time, if someone comes in and fills it, like your next day patient, like we're restricted. So it's unfortunate. And so then you're juggling, okay, well, we got to switch them to another pharmacy, right? But then we've been taught what? No pharmacy hopping. So then you got to call that pharmacy and say, this patient's not pharmacy hopping. I literally just need to get this med for this patient. So it's so much time, but it's a system issue.
I think we hit on honestly most of these. I'm trying to skim briefly. I think the one that we didn't hit on the top 3 listed on the slide, I'm probably the most passionate about. Stigma, I think we all here are probably pretty passionate about how much stigma negatively affects care. So the things we're talking about usually are system issues, but that's not to say that you all probably have not encountered a pharmacist that is just a jerk and that just says, no, I'm not filling that because I don't want to, because that does happen. And that's very unfortunate, but I do say that is partially, it could be a system issue, because at least speaking for myself through pharmacy school, I got no training on substance use disorder. Buprenorphine, I knew it was a drug and I knew it was kind of an enigma. With opioid, kind of, sort of, that's all I knew. And so coming out, even as a retail pharmacist, I worked at CVS and Target, and even coming out and filling these buprenorphine prescriptions, I didn't know what they were. I would check cures, I would go through all the steps, but I didn't have a true understanding of what we were even treating. And so that is a system issue. We have a lack of education with buprenorphine and with substance use disorder. And then we also have a lack of funding for continuing education in the retail setting. So a lot of those organizations don't provide CE credits or don't provide, professional leave days so they can do these CE credits. So I think that we could probably talk about barriers to pharmacy or with pharmacies for a while, but is there anything else anyone would like to add before we move on from this topic? Okay, I do want to point out that the words in blue are where I think we could probably make the biggest impact. So we'll talk about how to mitigate some of these barriers in a little bit, but just keep those in your back pocket. Okay, so I'm curious to hear if you all have experienced any barriers to medications for opioid use disorder from the provider standpoint. No?
I have providers that won't get their X waiver. I have providers that refuse to get their X waiver. I have providers that will not write for any buprenorphine at all under any circumstance, not for pain, not for substance use disorder. No bup. And this is not like 2 years ago. I'm talking like last week. So I get referrals from all over UC Davis. So I take referrals from primary care physicians from every clinic at UC Davis and the pain group, and also the addiction psychiatrist. So I use buprenorphine for chronic pain. I do half pain, half substance use disorders. And so I work with everybody, and I have certain clinic culture. I know which clinic won't prescribe opioids. I know which providers won't cover for each other and sign each other's scripts to keep a patient out of withdrawal. So I have had that happen as well. So there's that, huge access issue for that.
Any other examples? I have one that I'll share then. This is probably a very heart-wrenching example or gut-wrenching example, but and it's by far the worst that I've encountered yet. there was a scenario where I was doing kind of, I mentioned I do some order surveillance. So when patients come in on certain medications, I specifically methadone, I will, look at their orders and make sure everything looks good. And there was one specific patient that when I was looking in the chart, there was some mention of this concept of bargaining with the methadone. So saying, if you don't get this treatment, this, x-ray, then I'm not going to give you your methadone today. And so that was something that I thought I was dreaming. Like I was like, this can't be real. And it happened, and it was documented very evidently in numerous notes. And so at that point, I was like, I don't really even know what to do with this information, And so we definitely got the patient their med, and it was escalated appropriately. And thankfully, like I said, we have a really great substance use disorder group at UC Davis. And so the physicians, once I told them about it, they took it into their own hands, and they really provided that peer-to-peer education and made sure that it would not happen again. But like I said, that's probably a pretty drastic example, but unfortunately that was a very real one that I have seen. Sure. Yeah, so creating kind of that enhanced or added, unnecessary risk to the patient. So when patients, for those of you who are online, when patients, admit that they may have a problem or maybe think that addiction is playing a role, that provider may have an X-ray, or in this case they do, and they just continue to prescribe full agonist high doses. So creating that excessive risk for those patients. Yeah, so creating or like viewing clinical guidelines as like rigid, hard stops of like stepwise, this is what we are going to do. And kind of taking that patient assessment, patient dynamic out of it. Because of course, guidelines are exactly what that is, right? It's a guideline. So it's great to try to follow it, but every patient's different, and we have to tailor kind of what we're doing to each patient. Definitely. Okay, those are all great. So these, a lot of the core ones kind of overlap with what we talked about with barriers with pharmacies and pharmacists, specifically the stigma, the unfamiliarity, or lack of potentially the education component in medical schools, or any sort of PA or nurse practitioner school. And then the perceived liability is kind of definitely on the pharmacist side too, but also on the physician side. I know that in California, we're very, very fortunate that we have a lot of support with prescribing, medications for OUD, but I can't say that that's the same across the nation. And so while in California, that's the case, I know that there are other states that are very, very conservative with prescribing any opioids, including buprenorphine. That's, kind of a hybrid. And so that's definitely something that we have to continue to work on. And then the volume of work, which I've mentioned, numerous times, the burnout and the just the inability to continue with the education, or really the compassion fatigue that can happen after you've been in practice for a little while. So how can we overcome some of these barriers? Have you all implemented anything at where you practice on overcoming some of these barriers? Have you had any successes or any fails with ideas that you've tried? So there's a monthly MAT meeting, and trying to provide some targeted education during that MAT meeting, and then also bringing snacks or food. Definitely. Sure.
Going physically to meet someone, knowing each other.
Yeah, so building that rapport, that's amazing. We're going to move on that one. So I have more to say about that. We'll come back. But here are kind of our barrier mitigation strategies that have really worked for us and that we would recommend to other institutions. So they kind of overlap, as you can imagine, but using a closed loop healthcare system is a huge, huge win. So if you're at a healthcare system or your patients are at a healthcare system where you have, the hospital and the ED, and they also have a discharging pharmacy or a retail pharmacy that uses the same system, though having those pharmacists have access to the EHR and to the care plan that was developed in the emergency department or in the hospital has been huge. And so it really breaks down some of those barriers of our retail pharmacists feeling like they're in the dark and like they only have the patient's name, date of birth, and allergy list, right? So that's been really great. Transparency. So proactively including information on prescriptions. So whether that's the XDEA number or contact information for who to contact with questions. I know Becky on her prescriptions, she has an office phone, of course, and so does the providers have their own phones, but Becky will put, please contact Becky Haas, and then her office phone number. And so if the pharmacist has any questions, they have someone and she's the one who answers the phone. So they don't have to go through a receptionist and get, handed around. Collaboration, of course, is key. Building rapport, kind of like she had mentioned, and then inclusivity. So making sure these conferences are amazing, and conferences are how we educate each other. And so making sure that we're including all clinicians in the process to, join these conferences and to sit in on these conferences and present kind of our side of things, right? Because hopefully that after today, you'll have more empathy or at least understanding for what's going on behind that CVS or Walgreens counter. And then education, which I'm preaching to the choir here, but just continuing to provide that peer-to-peer education and bridging that knowledge gap for sure.
Quick shout out to Gloria Mealy for adding a pharmacist button to the registration for this conference. So for the first time I came, there's no button. And nobody had ever seen a pharmacist at this conference. It was like, and they started talking about pharmacists, and I was like, hi, yeah, I'm a pharmacist. And all the room got quiet, right? They were like, oh no. They were like, whoops. And I'm like, yeah, we need to be here. And so I'm a sub pharmacist. I see patients, I treat patients all the time with substance use disorders. CSAM conference just happened last week, no pharmacist button. No, and the addiction psychiatrist went and I said, any pharmacists, presentations? Nope. Did you see any pharmacists there? Nope. I'm like, cool. I'm like, we have a long way to go to include the pharmacist. So if you disinclude a vital member of the healthcare team, right? And all we see is name, date of birth, you might get some resistance. So we need to be part of the conversation.
All right, and so this is the last slide. I wanted to share a win. So going back to providing education and building rapport. This was something I honestly didn't realize how impactful this was going to be until looking back at it now. So like I said, we have a closed loop system at UC Davis with a Pavilion pharmacy that does discharge prescriptions. And one of our substance use physicians escalated a report to me that we had a pharmacist there refusing to fill buprenorphine for who knows what reason. The attending even talked to this pharmacist and gave a rationale for that medication. Still, it was a hard no. And so, of course, after my blood stopped boiling, I was like, okay, what can I do to fix this? And so I created this just one page. Becky actually helped me create this one-page handout with some clinical pearls about buprenorphine and opioid use disorder. And then also some microdosing, since that was the buprenorphine microdosing was relatively new at our institution at that time. But most importantly, I put some contact information and I went and talked to these pharmacists. So I took this handout and they had daily huddles. So I went to 2 of their daily huddles. I introduced myself face to face. And, I just told them, I've worked retail. I've been in your shoes where I feel like I'm just being told what to do and I'm not part of the decision. But I want, and I really gave them, the empathy that they deserve and told them, I'm here to support you and I want you to feel comfortable with the meds you're dispensing. So how can we make that happen? And so I gave them my cell phone number and everything. And they'd honestly, since then, this was about a year and a half ago, they've only contacted me maybe 5 times. And so I was like, I wonder if, if that even works. But the fact that I haven't gotten a single complaint from any of our SUD physicians since we did this education, I think speaks volumes. So our pharmacists feel like they're part of the decision and part of the team when they were dispensing those meds, and still continue to. So I think this is a huge win, and it really, really speaks to what you were saying about building rapport and building those human connections, and not just pointing fingers. And hence our title of our presentation, DAW1, Dispense as Written, making sure that we're having the dialogue. Okay, so with that, we'll take any questions if we have time for questions. And then, sorry, one more thing. I do want to say a special thank you to Dr. Francis Southwick for their very creative title. I would say that my instinct is that stigma. And unless Becky, unless you have something else to add.
What they're probably inferring is that they're talking about the mono product, buprenorphine tabs, versus the combo product, Suboxone. And what we actually know through trials and data is that the naloxone doesn't actually do that much. So they're the same. And actually, this just came up right before this presentation. I had a patient, and I saw this patient for pain. He had had 3 pain pumps placed, multiple revisions, multiple infections, osteo, you name it, he had it, where his pain pump had failed. And so he got plunked on Dilaudid, a ton of Dilaudid, paraplegic, lived in a rural area, had access to one pharmacy. And I won't say where, but it's here in California, and you might even know this person. But so I was actually out that day, and another pharmacist was covering for me, and I had sent a script for buprenorphine because we were going to transition to buprenorphine for pain. And pharmacist got a call from the pharmacy, and they said, I don't fill Subutex. I only fill Suboxone for OUD. I don't fill it for pain. We don't carry Subutex at all. And the message I got was a complete and adamant refusal. And there's actually been studies that have shown that independent pharmacies are actually harder to get to fill buprenorphine than retail. And why? Because they can make their own decisions. It's their pharmacy, right? They're not, the man is not controlling what they do. So they can pick their clientele. So huge stigma thing, right? So I'm boiling because I'm like, oh man. And the specific provider that had written the script wouldn't write for Suboxone. So there was stigma from the provider because he didn't want to write for Suboxone because he was worried about his liability, even though Subutex is indicated for OUD, not pain. Same thing, right? Same stuff. Doesn't matter. It's bupe is bupe. Doesn't matter which one you use. They're equivalent. If I'm giving it for pain, they're equivalent. So my provider wouldn't write for Suboxone, and my pharmacist won't fill Subutex. And I'm like, oh man. This presentation was so timely. I was like, okay, here's my chance. I got to figure out how am I going to get this to happen. And I called him up and I just said, hey, I just want to, I'm Becky. My name is Becky. I'm a, substance use disorder and pain pharmacist at UC Davis. Just wanted to get a feel for your policy surrounding buprenorphine and hoping we can chat about it. He said, yeah. He's like, I don't do Subutex. He's like, I actually carry Subutex, but I don't dispense it unless they have a documented allergy to Suboxone or they're pregnant, which we know new data, right? Doesn't matter. You can give Suboxone to pregnant patients. That's old school thinking now. So he's just not up to date. So we talked a little bit more. I told him the patient situation. I said, I got to tell you, I was like, I'm dealing with some stigma from my provider. That's hard, right? So I used a little verbal judo on him a little bit with that. And, because he was stigmatizing, right? So I used that a little bit. And I said, I'm trying to do what's right for this patient. He's getting snowed out on the Dilaudid. You know, he's had this risk of overdose in the past. He can only come to your pharmacy. He's a long-term patient of yours. We're really stuck, and my provider won't use Suboxone. And this is what we really need to do. And honestly and truly, I have data to show you that Subutex and Suboxone, you can misuse them equally. So it really doesn't matter which one you give. And he's like, okay, I'll do it. And I was like, yes, I can tell this story. I can. And so I literally, I mean, he put it all down, and he goes, you know what? He goes, I'm the main provider. I'm the main pharmacy for the substance use disorder treatment clinic here. So he's like, I dispense Suboxone with my treatment team. I'm that pharmacist. So he was just like, he has all this knowledge. And he's trying to do the right thing, but he was just slightly misinformed. And my stigma or my bias is this guy's being nasty and won't fill for my patient, you know? So, I mean, I couldn't believe it when he said like, he was the one that had done this for all these patients. I was like, oh man, okay. I'm glad we had this conversation. So anyway, patient got the med, but that one phone call, it took an extra couple minutes on the phone, but it was hours away. I couldn't go there. So anyway, that's that story, but success.
Oh, yeah.
Oh yeah. Yeah.
So this is, I'm assuming, and correct me if I'm wrong, please, Karen, in the chat. It sounds like insurance may have been maxing buprenorphine to a set like 24 milligrams per day. And so the question is, you know, do we taper everyone to 24 milligrams per day? And or I'm wondering if Karen's also wondering kind of where this came from. Typically, we can overcome those insurance requirements, so to speak, with prior authorizations. And even if those prior authorizations get denied, if you have a pharmacist on your team, they can call and they can get those undenied and they can actually get those approved. And so the rationale behind insurances requiring max doses, I don't know. Maybe Becky can speak to that.
I've written a lot of drug appeals on this exact thing. I have like a template saved. I have a template saved with actual, if you send the insurance companies as many drug studies as you can to support what you want, they usually will pay for it. So the key is to have your template ready, your drug studies ready. If you get that frequent one, and that's a frequent rejection, the insurance won't fill over 24 milligrams. So, but I usually can get it appealed. There's also GoodRx too. So in case that were to happen and you couldn't get it approved, sometimes I switch patients to Subutex and use GoodRx as an option because that's the least expensive product, and GoodRx coupons can be really helpful for those patients. Thank you all.
Yeah, thank you so much.
Thanks for having us.
Thank you.